a very good morning, all of you. And we are here with the next session of this course on understanding and exploring epidemiology. And we are very happy to have with us today our speaker for the day, Dr. Vidya Mave. Dr. Vidya is a MD, MPH, and she is the director of Indo-John Hopkins University Research Program, as well as leader of Bairamji Jijiboy Government Medical College. Popularly, we know that it is BJ Medical College, and John Hopkins University India Clinical Research Site, which is located in Pune. She is also Associate Professor of Medicine with the John Hopkins University School of Medicine. She directs a team of approximately 200 personnel in India and leads epidemiologic and clinical research on adult and pediatric tuberculosis, HIV/AIDS, as well as infectious disease for past 11 years. Dr. Mave has an extensive record of research in India on TB, HIV/AIDS, and antimicrobial resistance. Her research work is funded by government, US and Indian government agencies, as well as national and international foundations, which focuses on TB, including diabetes and HIV. The use of novel tools, including hair pharmacogenetics, kinetics, whole genome sequences, and host biomarkers. Tejaswini, can you please mute the participants? Yeah, sorry for the disturbance. Yeah, Dr. Mave has been chair of Indo-US Report India Phase 1 Common Protocol, which facilitated the biomarker discovery among TB participants and their household contacts who are at a risk of TB infection and disease. She has been involved with Pune Knowledge Cluster COVID-19 Epidemiology Group for last 15 months. She has been part of the 2 World Health Organization WHO workshops that formulates guidelines on HIV, TCT management and TB clinical trials and designs respectively. Dr. Mave has more than 20 years of experience in clinical trials design respectively, and clinical practice, education, research in infectious diseases, and has published more than 100 peer-reviewed research articles. So we are very happy to have you here today for the session, Dr. Mave. And over to you.
Thank you for the kind introduction. Welcome you all. So right now I'll be sharing my screen. Please let me know if you can hear me and also whether you can see my screen.
Yes, we can see the screen.
Okay. All right, welcome one and all. So I've been asked to talk about design of epidemiological studies. So I actually kind of made it into 2 parts because there is 2 lectures, one today and another one is on Friday. And so today you already heard quite a bit about the epidemiology, what it means. I'll be just, to start the subject to give a brief overview, and we'll talk about descriptive studies and a cross-sectional study today. And in the next session, we'll be talking about experimental studies and observational studies. So that is how I have made this kind of divisions for the two sessions. Just to recall what you have already learned in the past, epidemiology is a study and analysis of the distribution, patterns, and determinants of health and disease condition-defined populations. So basically what we are trying to see is when there is a disease, we want to identify among different populations how that disease has been distributed. What is the incidence? You already know the definition that I was told, a prevalence, and who are getting affected. Is it the elderly, children, or a working population or women? And then how we can control that disease, what kind of medications or what kind of controlled experiments, for example, containment or lockdown in the case of COVID-19, whether that helped control that disease in the population. So what it does is when we are studying these informations, then the local health authorities or national health authorities can make decisions on what they should be doing. Let us say for COVID-19 third wave happens, do we have enough information on COVID-19 to say lockdowns is more useful versus containment more useful, or testing and quarantining is more useful in controlling this disease? So basically, and then also making a policy decision on who should be targeted for preventive healthcare. For example, we know for COVID-19, elderly populations or those with diabetes or hypertension are more at risk for hospitalization and deaths. So maybe they are the groups which are to be targeted for a new COVID-19 vaccine. So this is how the epidemiology studies help in forming policy decisions all over the world. So what do we assume when we are looking in epidemiology? We know that disease doesn't occur in a vacuum, meaning that it is not really randomly distributed. It doesn't happen that a disease, so for example, I put an example here, SARS-CoV-2, a coronavirus 2. SARS stands for severe acute respiratory syndrome, coronavirus 2. This affects certain people more often than others, or maybe not. So this is how we do the study for epidemiology, where we do systematically study who gets infected, who do not get infected. Among those who infected, who gets hospitalized, ICU admissions, or who requires a mechanical ventilation, meaning intubation, a tube down your throat, and or death. So this is how an epidemiology can use a systematic approach to study the differences in disease distribution and then find out what is the causal or preventive factors. Causal in the sense that SARS-CoV virus can cause COVID-19. But among those who COVID-19, certain risk factors, certain factors makes them at risk for hospitalization, ICU admissions, and or death. So this is what I'm showing here in this part of the slide presentation. So I'm giving you some examples of what kind of work we have been doing in terms of epidemiology. On the right side, we looked at what is the antimicrobial resistance and mortality among adults and children with community onset bacterial infection in India. This is basically done in medical college where I am working as a research person. And then second one is emerging infectious disease paper looking at what is the risk of tuberculosis among medical trainees in India. And then you all know about the first one here, the novel coronavirus from patients with pneumonia in China. This is one of the early publications for COVID-19 where they saw a cluster of people coming in with pneumonia. They have identified SARS-CoV-2 among them. And so now they are describing what exactly has happened among those pneumonia patients. Pneumonia means lower respiratory tract infection, that is a lung infection for people who are very new to medical science. So this is a description of epidemiology. This is published in one of the premier journals, or the premier journal, New England Journal of Medicine. And then several others here. The one which I'm showing here is the maternal tuberculosis, the risk factors for mother-to-child transmission of human immunodeficiency virus, HIV virus, is talking about causal relationship. So there is maternal tuberculosis, the women who have tuberculosis increase the risk of transmission of their HIV from them to their children, for example. So these are some of the examples of how the epidemiology studies can happen. So what basically happens with the epidemiological studies? We actually measure disease frequency, quantify disease. You already know how to quantify disease prevalence and incidence is how we quantify disease frequency. And then we assess the distribution of disease, who is getting disease, where is disease occurring, when is disease occurring, and formulations of some hypothesis based on the information we have collected for this disease. And then these hypotheses can be tested in some kind of epidemic studies. I'm giving an example here. So this is one of our papers I already talked about, tuberculosis risk among trainees. So in this paper, what we did, we looked for incidence of tuberculosis among medical residents versus nursing students. So among nursing students, medical residents. So then we asked where it is happening, who is getting disease. We are looking for medical residents versus nursing students. Medical residents having more at risk of acquiring tuberculosis than nursing students. Medical residents meaning they have finished their MBBS and then they are now getting specialized in medicine or chest medicine or surgery or OBGYN and so on, or obstetrics and gynecology. And then they work in medical wards, or they might be working in laboratory, for example, microbiologists or pathologists. So where they are working, whether that made any difference in them getting tuberculosis while they're working in clinic. And then we asked, when do they get this tuberculosis risk? When the remote risk happens? This is the first year of their work versus second year of work or third year of their work or their training that is happening in a clinical ward or a laboratory. So then we generate a hypothesis. We found in this study that medical residents in the first year of their training developed TB. So maybe that is more common. So has this kind of study has happened in the past, then that helps us to decide whether this hypothesis then which could then be tested in another cohort. So this study was a retrospective study. I mean, we'll describe what retrospective study means in the subsequent slides. And so we have done this retrospective study. We have this perhaps a finding from this study. Now we are going to look forward to say, do a prospective study to see whether this is true or not. And so we are looking at people, we are looking at where it is happening, and then when it is happening, the time. And that is how we kind of identify epidemiology of that disease. For here, in that example, is tuberculosis. So there are two types of basic studies. One are descriptive studies, which actually talks about occurrence of an outcome. So outcome meaning in terms of COVID-19 disease, COVID-19 disease itself is an outcome. It could be an outcome where once COVID-19 happened, then somebody got hospitalized, ICU hospitalization versus requiring mechanical ventilation versus they are dying. That could be also an outcome. Analytic studies describes the association between an exposure and outcome. So exposure to that of coronavirus and outcome getting coronavirus, or having already a coronavirus and then they got certain kind of treatment. Either they got an antiviral called remdesivir. You may have heard it in the newspaper. Remdesivir. When you given a remdesivir on a coronavirus patient, what exactly happens to them? Do more people who got remdesivir get better or worse? Meaning better, worse outcome could be hospitalization, ICU admission, mechanical ventilation, or death. It could be any of them. So some of the descriptive study designs include case reports, case series, and some descriptive epidemiology paper. There is analytic studies are randomized control trial, cohort studies, case cohort studies, case control studies, cross-sectional studies, and other studies like case crossover studies. So today we will mostly concentrate on descriptive studies, and we will touch upon cross-sectional study as well. So we have all these different kinds of studies which are shown here. There are case report, case series, descriptive epidemiology. Then there is an analytic epidemiology, could be observation cohort, case control studies. And then there's also clinical trials. And then there are another section of studies called animal studies and some cell-based studies, some laboratory studies. So where do they all stand? What are kinds of these different studies which are available to understand the epidemiology of the disease? Where do they actually place themselves in terms of strength of evidence? Strength of evidence, what I mean by that is that which studies considered to be the very highest standard studies? Can anyone think about and let me know which study would be? I mean, people who are already having advanced understanding of epidemiology would know that randomized clinical trials are the ones which are considered to be having highest evidence. They provide the highest evidence. Then the second highest evidence are given by cohort studies. And the third one is case control studies, and descriptive studies are the ones which are considered to have a weaker kind of strength of evidence. Means that when people come up with the guidelines based on a clinical trial, that guideline is considered the highest evidence. People do come up with guidelines with the cohort studies when they are thinking about how the exposure happened and outcome happened. And then when there is no randomized control study results are not available, there is only cohort study results available. They do come into picture in terms of guidelines, WHO guidelines or national guidelines and so on. Then case control studies are when the exposure happens. So let us say somebody got a exposure to a lead, and that actually children getting exposed to lead as a chemical, and then that actually leads to, or a mineral that leads to then a cognitive impairment in the child. Cognitive means they're having little lesser mental acuity. That is a kind of a case control issue saying whether this happens or not, where people who got exposed to lead versus who did not get exposed to leads are studied, and we look into whether what is the outcome among them. And descriptive studies, which we will discuss today, are the ones. There are three types of descriptive studies: case report, case series, and descriptive epidemiology study. So case report is basically one case of an unusual findings, or maybe one or two cases of unusual findings. Case series are multiple cases of findings. There are like quite a few numbers. So it's not one or two or three, it is much more than that. And descriptive epidemiology study is basically a population-based studies where a large population is coming into picture, and we are trying to see in that population what exactly happened with this exposure, with what actually happened to them over time. That is simply a descriptive epidemiological study. So as I already said, it could be a single case or a handful case. It could be a previously undescribed disease. We all heard about black fungus and yellow fungus in the newspaper within the last several months. So I put those examples here. Previously undescribed cases, for example, yellow fungus in COVID-19, maybe very, very rare. It's not that common. We have never heard of a yellow fungus before, but we are hearing about it now. And so unexpected link between diseases. So COVID-19 treatment happened. They became better, but now they have a black fungus. The first couple of cases became a case report, and they were actually seen in not India, but elsewhere. And it came in some prominent or premier journals that they have been seeing some 1 or 2 cases of black fungus among COVID-19. And then the third thing, unexpected new therapeutic effects. So for example, people got dengue infection. Dengue is a mosquito-borne infection. And people have no treatment for that. Basically, there is no antiviral which can take care of dengue infection. So viral infection, mosquito-borne viral infection. So somebody thought, let us give somebody papaya extract, the skin of the papaya extract. And so he found that, it seemed like the symptoms are getting better faster. So this then becomes a case report. 1 or 2 cases where papaya extract was given on a dengue patients who got, better or were not, that becomes a case report. And adverse events, for example, it could be related to medication or it could be related to disease itself. For example, we found out initially, first few cases of COVID-19, people saw that the elderly individuals or who had diabetes or high blood pressure were getting all these blood clots. And that was making them, having them to have a heart attacks or a stroke and stuff like that. So these are adverse events that happen among COVID-19, which are unexpected because a viral infection generally doesn't do that. So this was unexpected result, then it became a case report. Initially case report, then it became case series. So this is before COVID-19. This is a publication from within India, where this case report talked about rhinocerebral mucormycosis. So mucormycosis is a black fungus, as you know. Rhinocerebral, rhino means nose. So it actually was a fungal infection in this elderly gentleman who had a diabetes. And then this infection was starting from his nose, and it was spread to his brain, inside the brain. And so what they did, he actually came with the complaints of face pain. And then they did in a CAT scan, and they found that his sinuses were infected, like here. And the most common treatment for black fungus, which is actually highly invasive. Invasive means it spreads fast, it infects all the cells around you. And then they did the debridement. They kind of surgically removed all the pus outside, and then did a stain here, pus stain, and they saw this envelope-shaped fungus. This is the envelope-shaped fungus. So this is a case report. So this is kind of describing what exactly happened to this person, one person who came up with these symptoms, and these were the findings for him. So this is a way to let other clinicians know that this is how the presentation happens. So in the future, a clinician sees a elderly gentleman or woman who has had diabetes, but has a face pain and have all of these symptoms. You should be doing a CAT scan and then doing, referring them to an ENT surgeon so that they can do the debridement. So this kind of gives them an information about this disease. What is a case series? Again, it's the same thing. It's like a case series, but there are a group of people who are having a similar kind of disease or similar kind of presentation. What it does is kind of helps us to understand it's quite a prevalent disease, right? It's not happening in one person, it's happening in a bunch of people. And then these cases can come from one source. It could be like coming from one hospital or multiple hospitals, or it could be hospital and clinics. It could be various settings. It could be happening in Pune versus Mumbai. It could be different sources. Different people can come together and say, this case series happened. But it's usually one condition or one description which has happened to many people. It is this kind of case series, if there is an uncommon disease that happens, let us say there is this hormonal disorder, it happens in the bones. It happens quite a rare kind of condition. It can happen in kind of autosomal recessive kind of structure. And so, but it's very, very uncommon. So then there is no way to study them. So then people come together and say, I have seen so many cases, 2 cases in my last 20 years, and somebody else has seen 2 cases in another 20 years. So those 2 people come together. So they have like 5 cases, and then they approach another person who also treats similar kind of cases. Then he has another 3 cases. So bring them together, and then that becomes a case series, kind of a description for a clinician in the future to treat and manage those cases. So this is an example of a case series. Seattle is in the western part of the United States on the top. And there is a medical facility, which actually saw 24 cases of COVID-19. All 24 cases were admitted to intensive care units. And in this New England Journal paper, they then described all of these 24 cases, their clinical characteristics, what were their laboratory presentations, and what exactly happened to them when they were in ICU, whether they died or whether they survived, and whether were got discharged, they are still in care and are still admitted in the ICU, and so on, and what kind of therapies they received. They received remdesivir, they received steroids, or any other medications which they have received, and that kind of described them over time while they were in the hospital. This is called a case series example. So what does it do? How case series help us with? It is actually useful for hypothesis generation. So when people took care of this COVID-19 patients in ICU of a Seattle hospital, they started everybody on steroids. So when they started everybody on steroids, compared to a group of people who were admitted in a Chinese facility many, many months back, there was a difference in outcomes. So more people survived perhaps in Seattle compared to China. So that means that maybe steroids had to be a key medication that can be given to COVID-19 patients admitted to ICU, meaning that now you're generating hypothesis. You're saying corticosteroids are useful to take care of or to reduce worse outcomes among COVID-19 patients. And as I mentioned to you, if there is a very rare disease, then it's the only way to describe them. And it also helps us to understand what are the averages, what is the average number of mortality, average number of hospitalization, assessed with any diseases. But there is also some disadvantages with the case series. They cannot study cause and effect relationship. They cannot for sure say corticosteroids given to 24 people with COVID-19 is really helping with good outcomes. It looked like it did, but we don't know for sure. There is no cause and effect relationship that can be assessed by case series. And also it cannot talk about disease frequency, means it cannot talk about incidence or prevalence of the disease, because we cannot talk about that because all of them are COVID-19 patients. So descriptive epidemiology, on the other hand, helps describe the disease. It describes disease in more depth than that happens with the case series. It can also identify prevalence, incidence, clinical course, and outcomes of the disease. There are two types of such descriptive epidemiology studies can happen, prospective and retrospective. So I'm going to give you an example, our own example from our prior studies. This is a study which was published in Journal of Infectious Diseases, looked at prevalence of antimicrobial resistance among bloodstream infections among adults and children. All of these people were admitted in a Sassoon hospital, and we actually started a study in 1 year, 2015, and followed them and continued this study over 1 year. And then while they were in the hospital and they were having this bloodstream infection, we looked at what exactly happened to them, how long did they stay, what were the antibiotics given to them, and then how many of them had a better outcome. They survived, they got discharged, or they died because they have had these kind of infections, antimicrobial resistant infections. So there are prevalent antibiotics which are given by people who are admitted to the hospital with fevers or other conditions, and then when they come in with that, we kind of do certain investigations to them. Do they have malaria? Do they have dengue? Do they have infection in their blood? So we collect their blood and run it for some test. In that test, we identify whether they have bacterial infection in their bloodstream. If they do, then what kind of antibiotics can be given to those bloodstream infections? And when we are testing which antibiotic would be effective, means sensitive, and then that is how we identify whether there is resistance to that bacteria, resistant to that antibiotic with that bacteria. That is how we assess antimicrobial resistance. And so this is how a descriptive epidemiology study happens. We follow people either prospectively, this is what we chose to do here. We kind of followed them over time and said what happened to them if they have these kind of infections, or you can also go retrospectively backwards. So how does a prospective study looks like? They basically look like here. You start the study here. Then you start looking forward. What happens to them over time? And then while you're doing that, you look at an outcome. You look at whether they survived, they died, or they required some additional care like ICU care and so on and so forth, and identify, kind of describe what happened over time for them. A retrospective study, on the other hand, looks back. Study is starting today. So today you decide to look at COVID-19 patients in Pune since the beginning of COVID-19 pandemic. So COVID-19 pandemic in Pune began somewhere in March, April, and today is August 10th. So from, let us say, end of July 31st to that of looking backwards and to see how many people got COVID-19 among all who got tested. And of those people who got tested, which age group got the most infection diagnoses. And then of those who diagnosed with COVID-19, what exactly happened to them over time? We look backwards. We are not doing forward study, we're looking backwards. So that's called retrospective descriptive epidemiology. This is a paper which was published in one of the premier journals called Science Journal, which looked at one of my colleagues did this study. It was a kind of a prospective study where they went to governments of Andhra Pradesh and Tamil Nadu, and they collected information on COVID-19 participants. And then they looked at some key factors, like how the cases were distributed of COVID-19 in different parts of Andhra Pradesh and Tamil Nadu, and where were the new cases were diagnosed, which districts and which areas. And then they looked at how the daily cases happen in both those states, both those states over time. And then they looked at how was the cumulative cases happen, cumulative mortality, deaths happened over time when they were doing this descriptive epidemiological study of COVID-19 in 2 states. So what did it do? It kind of gave an idea. For the first time in India, data became available on the distribution of COVID-19, incidence of COVID-19 and water mortality. Here, the idea was to just do descriptive epidemiology. Idea is to show people what exactly happened. This is just very, very early data. So they started in 1st March and ended this study in 26 July of 2020. This is last year, previous year. So this is what the descriptive epidemiology does. It actually gives us an idea of what is happening here. So now I do have a couple of quizzes. People who would like to answer these quizzes can, kind of maybe, write the answer in the chat box. It's a simple question. Cutaneous mucormycosis means mucormycosis is a black fungus happening in your skin. It's a presenting feature. As a presenting feature in type 1 diabetes in a boy. So small boy, a 6-year-old boy who is having type 1 diabetes, means he has diabetes. He now has a cutaneous mucormycosis, and it was published in Indian Journal of Medical Research. So what kind of a study is that? Is it a descriptive epidemiology study? Is it a case report? Is it a case series? Yes. Many of you currently identified it as a case report because there's only single case is there. Now we're going to talk about a second. Okay, I'm not sure why I'm not able to. Okay, so the second case, second quiz is this is actually a published paper. This looked at presenting characteristics, comorbidities, and outcomes among 5,700 patients hospitalized with COVID-19 in a New York City area. So what kind of a study is this? Sorry. So some of you said it is a case series. Some of you said descriptive epidemiological study. It's basically a descriptive epidemiology because case series are like not a huge number. It is not 5,700 people. It is maybe like 15, 20, maybe even 40 perhaps. But it could be a case series also. Sometimes when a rare disease happens, previous to COVID-19, black fungus was a rare disease. We hardly saw them. And so there was a publication of black fungus of almost 800 cases. 800 plus cases in one journal. So that journal, that paper actually talked about 700 cases, different kinds of black fungus in affecting different parts of the body over a long time, 20 years. They looked at all the case series that happened, put them together and wrote a paper. That's basically a case series which described all the studies. But here in this case, though, however, this is a descriptive epidemiology study because this did not happen. It was not a rare disease. COVID-19, by the time this paper came out, was pretty common. And so they kind of wanted to describe in New York City, 5,700 cases were identified. So what exactly happened to them? What were their presenting symptoms? What were the comorbidities? What happened with different comorbidity people? And so on. So this was a descriptive epidemiological study. This is a paper which was, I was a co-author on this paper. This looked at 31 cases, kidney transplant cases. and they had a virus infection called cytomegalovirus infection or disease. So what do you think this is? This is a case series, case report, or something else? This is a case series, actually. There's a finite number of cases. It's not a huge number of cases. There were only 31 cases who were all African American patients. I was working at the time at Tulane Hospital in New Orleans, US, and so all of these African Americans underwent kidney transplant, and then they developed this cytomegalovirus disease. So that is kind of, in a nutshell, a descriptive studies, where basically what we are looking at is a description, basically description of different cases, different symptoms, or among one case or a group of cases or a large group of cases to help understand the epidemiology of that disease. So the next kind of studies are analytic studies. So here we are looking at a cause and effect relationship. Exposure happened and disease happened. Are there any relationship with the exposure? Is what we are looking at. So for example, we all heard about malaria. Malaria is caused by a parasite, blood parasite called Plasmodium. There are many types of Plasmodia species are available, which can cause malaria, but I'm only giving an example, Plasmodium falciparum. It's a blood parasite, gives you malaria. So do we know this? We know that Plasmodium falciparum exposure must happen by biting of a female Anopheles mosquito, which actually carries this parasite. When it bites a human being, malaria happens. So this is an exposure happened, therefore the disease occurred. So this is a very clear relationship between the exposure and disease. So what is analytic epidemiology does, it actually assesses this link between exposure and disease. What is the exposure? Who are the exposed? And what are the potential health effects? And what approach will you take? What approach will you take to study this relationship between exposure and effect? For example, again, I'm showing you the same example. Female Anopheles mosquito carrying Plasmodium falciparum bites a human. He then develops an infection. And if there is an infection, it causes fever, body aches, shivers, etc. And then what happens to them? Are they recover, or few develop complications? And then in between, you can also look into whether when they develop the infection, we generally give them an anti-malarial antibiotic, mefloquine, for example. If you give that, antibiotic, antimicrobial, then are the recovery faster or not? You're kind of looking at exposure, effect, and perhaps even several other exposure that happens once you got infected, once you have malaria. So all of this can be studied with an analytic epidemiology. So, but why do we really need to do analytic studies? Isn't description enough? We already know what happens with different diseases, and do we really need to study further with the analytic studies that are required? It is required because they actually help guide control activities for the disease or prevent the disease, perhaps. I'll give you several examples as we go along. It also helps to identify hypotheses on what is related to disease and may be causing. And also it formally can test the hypothesis, whether certain things can lead to certain things. Somebody who has diabetes and hypertension and obese, do they get a heart disease? Are they at more at risk of heart disease? So that is what we are trying. We are testing hypothesis. We are going to get a bunch of people, let us say 100 people, 30 of them are obese, diabetes, have hypertension, diabetes, 70 of them do not have it. Then we look at how many of them develop heart disease over time. And we say people who have diabetes, hypertension, 30 of them, about 25 of them develop heart disease in 5 years, as compared to maybe 10 people of 70 people who did not have any of them develop heart disease over 5 years. So who are at more risk? for heart disease, then we are developing hypothesis. Our hypothesis says people with diabetes, hypertension, or overweight are more likely to develop heart disease. So this hypothesis we are testing in this study where we are following them for 5 years, for example. There are several study designs in the epidemiological analytic epidemic study. Some of them are shown here, randomized controlled clinical trials. This has the highest strength of evidence, as I mentioned earlier, and we will discuss this trial next week or on the next session. There are observational studies like cross-sectional studies, which we'll discuss today, cohort studies, and case control studies. Case crossover studies are similar to case control that requires a lot more understanding of study designs. So what does observational studies mean? Observational studies are non-experimental. You're not doing any experiment here. You're just observing people, a group of people. There is no individual intervention. We are not giving them anything. We are just following them over time and looking at certain exposures and outcomes. And it occurs in a non-control. We are not going to control anything among that population. And as I mentioned earlier, as similar to descriptive epidemiology, which can happen prospectively as well as retrospectively, even observation studies can happen prospectively or retrospectively. So I think we are doing good on time. We will now move on to cross-sectional studies, a type of an observational study. Here, the very good example of these kind of cross-section studies are usually surveys. Their surveys are done for exposure and disease status, a single point in time. So that is what a cross-sectional population getting surveyed. I'll give you an example a little later time. So here, basically, what we are trying to do here is that at this time, one exposure is happening. We are understanding what exposure happened, whether the exposure led to any disease in that person. It's like, or for example, COVID-19 serology testing. So as several of you may know, that the government of India did a massive sero survey in India, in different rural and urban areas and so on. So what they were trying to see is, at that time point, in that month or in that 2 months or 3 months, they wanted to identify how many of the population, urban and rural population in India and different regions of the country have had COVID-19 antibodies in their blood, in their sero survey. So this is a cross-section study. It is not looking at over time what happened. It's at that time period, how many of them developed COVID-19. So here, what we are looking, even though it's a cross-section study, only one time point is being looked into. This defines the study population, entire urban and rural study population, whether they have disease, that they have COVID antibodies or not. Here I said disease or no disease, but survey is one good example. We can also say survey of malaria, for example. If you're doing a survey of malaria in the city of Pune in the monsoon season, between June and September, mid-June to mid-September. So how many of them in that time in the monsoon season? One time point you're looking into that. One time only you're doing this test, malaria test, and whether they have disease or not. And then you can find out which area they live in, or whether there was water which is non-flowing water available in that area, or a pond which is not clean, or is so all of those factors you can look into what kind of exposure led to having this disease in that population. So there is going to be an exposure or a cause and effect, whether that led to an effect. More mosquito in that region, for a public health perspective, it's very important that mosquito control happens. So for public health personnel want to know this information, cause and effect. So there is a lot of water, still water, which is a mosquito breeding area. Then therefore, these mosquitoes bite that population, and that population, therefore, in this region of that population developed higher proportion of malaria in that area. This is a cross-sectional study, but so it is usually done with relatively frequent infections or disease with the long duration of expression. For example, malaria. When we think about it, it is although falciparum malaria is pretty acute kind of condition, it is not like if you get the malaria today and tomorrow you're cured. It's actually, it has about maybe like 2 to 3 weeks or something. You can also talk about tuberculosis. Tuberculosis is a subacute infection where people, or disease, where people have symptoms for a time, from between 2 weeks to 4 months, sometimes even longer. And then they present to the care and then have this condition for 6 months before, when the treatment initiates for 6 months, then they get cured or completely cured. So this is kind of a longer term duration. This is a good study. Cross-sectional study can help understand the exposure and outcome for a disease which actually has a longer kind of a duration of expression, in the sense presentation or symptoms or signs. So what it does, cross-sectional studies, is measure prevalence, not a new infection. What is a burden? How much infection is present right now? That is what it is, or disease present at this time. That is a prevalence. It's not an incidence. So generally, as I said, community surveys are generally the most common example of cross-sectional studies, but it is not suitable to study rare diseases or highly fatal diseases. So I'm giving an example here of a paper which we wrote in the beginning of COVID-19 pandemic. Everybody were anxious and concerned what is going to happen with COVID-19. At that time, we were doing a survey among HIV-infected people who are visiting our hospital. And we asked whether they are anxious. So we interviewed about 157 people who agreed to be part of this survey or this interview. And of those people, 25% reported anxiety. They were feeling very anxious. And some of these concerns, why they were feeling anxious, some of them are health related, some are unrelated, and I'm showing here. So most of the concern they were expressing could be put into these 3 or 4 health related or health unrelated kind of reasons. As you can see, lack of social and financial support were their major concerns, and they were concerned about their immediate present in relation to health. For example, whether if they are more susceptible to COVID-19. At the time, we had no information about what happens for COVID-19 if it occurs among HIV-infected people. So they were worried, what will happen if I get HIV? I already have HIV. What happens if I also get COVID-19? Then they were also worried about in the future, what will happen? Would I be able to get my medicine, which I need to take every day for my HIV? Would I be having a job, unrelated ones? Would I be having a job? Because a lot of people, the lockdown happened and all the shops are closed. People who have their own businesses are not able to open. How will they get financial support? And so on. So this is a survey. This is actually an interview. It happened. It's a cross-sectional survey or cross-sectional interview. So it did not look at over time. It at one time point, we looked at what is the level of anxiety among HIV-infected population in the beginning of a COVID-19 pandemic. So it's not a perfect kind of analytic study because it's a weakest design. It only measures prevalence of anxiety. It doesn't say how many were newly having anxiety over time. So it's not an incidence. So, and also there is a problem here is that prevalent cases are the ones who already survived that anxiety, right? You got anxiety, but you are, maybe you developed depression because of anxiety, but then you didn't do anything about it. Like a lot of people who have anxiety and depression may be prone to having suicide. So then they may not survive, right? So, but these people are survivors. So that's how you cannot talk about what is the effect of COVID-19 on anxiety and outcome of anxiety, because we are not going to look at outcome here. We are only looking at anxiety. So there is a temporal sequence of exposure effect, may be difficult or impossible to determine in cross-sectional surveys. And often we don't know when the anxiety occurred. Did it occur just because COVID-19 happened, or they were already worriers? They were already having anxious otherwise also. And also quickly emerging diseases are a problem, and rare events is also a problem. So here I spoke about the Zero survey which Government of India did. So this is a newspaper article which said that 68% Indians had COVID antibodies and 1/3 are vulnerable. By what they mean is about another, 32% do not have antibodies, so they are vulnerable to COVID-19. And they kind of talked about what are the age groups who had COVID-19 antibodies and urban rural areas and stuff like that. So what is this study? Can you write in the chat what kind of disease is this? What kind of study design is that? Obviously, it's a cross-sectional study design. So now I want you to let me know. So yes, I already answered that first question, true or false. It is true, right? It's a cross-sectional study. This is a series or zero survey of Indians for corona antibodies. So is it true? Can you do, can cross-sectional studies assess prevalence? That's correct. It is prevalence can be identified by cross-section studies. It's a best observation design, true or false? That's right, it's false. Most of you have answered this correctly. It is a false statement that it is not a best observation design. So at the end of today's session, and I actually don't know, I'm not watching the time. It's 11:52. So we studied overview of epidemiology, what are the descriptive studies and observational studies, and learned about cross-section studies today. I am happy to take any questions anyone has. Dr. Aarti, can you guide me how this will happen?
Students usually type their questions in their chat box, and I can compile them for you. Or there are some questions which are directed to us privately. So I can ask those questions. I have noted down few questions already. So thank you so much for a very nice presentation. And there are 4 questions already in my chat box. And first is, what is the purpose of case series? What is the purpose of case series when we already have case reports?
So case reports is 1 or 2 cases, right? It's not a huge number of cases. So it can only talk about, unusual occurrence, 1 or 2 cases. A case series actually talks about many cases. Then it actually gives us a trend, what happens. For example, when first 1 or 2 cases of coronavirus happened, people described it in such a way that 1 or 2 cases happen. I don't know why people are dying. People are dying of some kind of viral infection. They're coming with like fevers and cough, and then they're getting admitted to the hospital, and then they died. We don't know what happened. So then when that is a case series, as opposed to, let us say somebody came up with a 24 cases, that's a case series. Then we came to know that coronavirus patients who are admitted to ICU, what actually happens to them? It's a large number. So case series. So case series is more, in an evidence base, in a structure of level of evidence, is much stronger than case report. Case report only describes 1 or 2 cases. But what case series does is kind of helps us to know what exactly happens to people who are infected with coronavirus or admitted to ICU. So it's a large number of people. Similarly, in the early case reports of a case series of coronavirus happened, it was published in Lancet and New England Journal of Medicine, which are very premier journals of the world. Then we came to know what are the presentations. So now next case that happened in India, for example, first initial case are described in China, happened in India, then we came to know that this is how presentation happens. So we were quickly able to identify them and quarantine them. So that is where case series are helpful, because it kind of tells us what a kind of different kind of presentation happens. Case series only will tell me 1 or 2 cases, while case series are on a group of cases what happens. So it's the strength of evidence is much higher.
Okay, thank you. Then there is a question about what is the difference between case report or series and case study? Is it the same?
Yeah, so people use different terminology. Case study, could be also case report or case study of a group of case series. So people use different terminologies, case study. For example, we recently wrote a paper we called it case study. This paper actually described how a COVID-19 pandemic was managed in Pune city. So it's not really describing what happened to the patient. It was how it was managed. It's a case study. We call it case study for that. But some people will say case report also as a case study, you know. So it's kind of a terminology, how you want to use it. You know, there is no clear distinction what you mean by case study is. So it could be either way.
Okay. There is one question. Is case series qualitative or quantitative?
Generally, case series are quantitative. It is not qualitative, and we are not going to talk about qualitative at all here. I think Dr. Aarti, you might be the best person to answer those questions. So qualitative studies are basically kind of, it could be also experimental studies where qualitative studies help us understand how the experimental studies effect happens in that population, perhaps. But generally, qualitative studies are, we do not consider them as a case series. We can consider them as a description or descriptive epidemiology kind of studies.
Okay. Then another question is, if we collect data from laboratory register, can it lead to case reporting of case report or case series?
Yeah, it depends on how many numbers again, right? If you have one case where you found out in the laboratory that there's a new diagnosis happened, one case, then it's a case report. Let us say, but you had a bunch of people whom you did a blood, let us give an example of doing a blood culture in a population. So you had a lot of blood culture that come to your laboratory, and of that blood culture, you identified a rare disease, one rare organism, then that's a case report. You're going to present that. As opposed to, let us say, you found out 15 cases or maybe 25 cases of a similar thing, then it becomes a case series. So that is, it depends on what you're describing in the laboratory register, from laboratory register. Then it could be a lot of people who have over time, who have had blood culture positivity of a rare infection. Then it could be a descriptive epidemiology too. It is quite common, but it has to be quite a common infection. Let's say carbapenem resistant Acinetobacter, you're seeing it in many blood culture being positive, then you want to describe that. That's a descriptive epidemiology then.
Okay. Thank you. There is a couple of more questions and not directly related to what you spoke today, but it says, do all epidemiological study require ethical clearance?
Generally, descriptive epidemiology and onwards require, ethics committee approvals. A case report generally doesn't require ethics committee approval, but you need to get the consent of the person. If you're showing his face, for example, I showed that one article of black fungus. In that person's face was shown, only eyes were covered, and so in that person, you have to ensure that you get the person's consent, because journals would require that. A case series, when you're doing an in-depth analysis, generally people do go with a lot of people to ethics committees. Only case reports perhaps doesn't require ethics committee approval, but everything else might require ethics, depending on the strength of evidence and new findings which you're putting it out. Yeah.
Then, thank you. And then one more question is how to decide the sample population size for cross-sectional study?
All right, so I am not going to be discussing sample size in this session, but generally when you have to develop or design any studies, a cross-sectional study or any study for that matter, you really do require a biostatistical assistance. So first in the beginning, don't do a study and then go to a biostatistician. When you are designing the study, you talk to a biostatistician who can help you with the sample size of the study. Generally, you are kind of doing an estimation. So based on a current evidence on a anxiety, for example, study which we did on anxiety, we thought that of 150 people who are randomly selected among our HIV population, could give us an estimate of, let us say 25% of generalized anxiety disorder. So cross-sectional studies generally look in based on what is the estimation you're expecting of that disease or a disorder. So it depends on, so you do need to have additional help and sample size calculation, but cross-sectional studies generally don't use that. You just estimate, you go out there, and it's a study which looks at one time. So it kind of develops a kind of a sampling processes for cross-sectional studies, especially for serosurveillance studies. And so you go from there. 1,000 is around the number for serosurvey. I think that was looked into, but sometimes you look at even larger numbers to get a wider representation.
And there is a request, if you could suggest good journals, and if you can suggest software which you use for your work.
Okay, so there is something called Pubmed. You can Google Pubmed. And then in the Pubmed, it's a National Institute of Health actually has an open source kind of resources where you can type in any diseases, case reports, and different cross-sectional studies and stuff like that. And then then so many of the papers which are published in good journals come up, and you can click on any one of them and find out about what different kinds of studies are there and how they are presented and so on. And regarding the software, I'm not really sure what the question is. Software for data analysis, it depends on the data analysis is depending on the comfort level of the biostatistician. In our group, we use Stata and R software.
Okay. Yes, there are many other which are available, and maybe it's
yes,
depending on kind of data and the depth of analysis.
That's right.
Choose. Okay, so thank you so much.
Yeah.
I think we will end this session. Yes, close this session now, because questions are many and people will keep on asking. If in case there is any question which we are not able to address, we'll get back to you next time, Friday maybe. And thank you so much. It was very informative. And I'm sure some of them will venture and publish case report at least. So Dr. Vidya, we are looking forward to meet you again on Friday and get detailed information on analytical epidemiological studies.
Sounds great. Thank you very much. All the best, everyone.
Yes.
Thank you. On behalf of Pune Knowledge Cluster, I thank you, Dr. Vidya. And looking forward for the next session on Friday.
Okay, bye.